Hello, hi, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. As usual, we have a great show for you tonight. But first thing I would like to say is that I would like to just talk about caring and sharing. And it's all about caring and sharing. You know, I so enjoy all the emails that you guys are sending to www.medmoments.com. The emails are appreciated because it gives me an idea of what's going on out there. And it allows me to share what you're talking about so that others can do better with their medical care. So www.medmoments.com. Let me know. Email me. Well, getting back to the show. Listen. We have a topic tonight, and that topic is COPD. And I have an expert in the field of pulmonary medicine here today. The doctor that I have with me today is Dr. Sean Studer. He is the Director of Pulmonary Medicine at Newark Beth Israel Medical Center. Dr. Studer, welcome to our show.
Thank you so much. Thank you for having me. It's great to be a part of it.
Oh, yes. I'm so happy that you could come and talk about COPD because, you know, that's my favorite topic.
I do know it's one of the things that you really hold near and dear to you.
Yeah. Oh, yeah. So I always like to start at a very basic level. And for our first question, what is COPD?
Well, it's a great question. It's four letters that I think get people confused because they hear a mix of terms. COPD broken down is chronic obstructive pulmonary disease. Mm-hmm. So chronic means that it's been lasting a while. Someone that's not short of breath a day or two, but it's something they have for months into years in most cases. The obstruction means that they can't move the air in and out of their lungs normally. Mm-hmm. The P is for pulmonary, means it's a lung disease, and the disease says that you're sick with it. So COPD really is a problem of not being able to move the air easily in and out of your lungs. Mm-hmm. But unlike perhaps asthma, where it may last a few minutes or a few hours if you're having an attack, these folks deal with it day in, day out for months into years.
Oh, goodness. So you're talking, that chronic part really is, it means lifelong. Once you have it, you're not getting rid of it.
That's correct. There's no known cure to COPD, but there are some ways we can try to treat it when people get affected by it.
Okay. Now, I know that we're talking about the lungs specifically now. I just like to go back and understand, how does the lung work? How do we put all the parts together so we understand what's happening to us when we breathe?
Sure. Well, if you open a book, the lungs can seem very complicated. We could probably break it down to something fairly simple. Mm-hmm. The lungs are a bunch of tubes leading to air sacs that the blood swirls around.
Okay.
So if you think of it like a car as an example, you have to bring in the fuel and you have to mix it up with air in order to get combustion and make the engine work. Right. Your lungs provide the air that allow your body to use the fuel you take in, and then like the exhaust system on a car, help get rid of the bad air so you can keep on going and keep on moving, doing what you need to do.
Oh, all right. So you're saying it's tubes, but I understand, so air comes in through my mouth, and then it goes into a particular tube, and then from that tube, it obviously goes into either tissues or cells or something like that. Describe what happens to the air once it goes through my mouth and it's heading towards the lung. What's happening there?
So the air first is just sort of traveling and not interacting with too much. It makes most of the trip to the end of your lungs just sort of on its own. So it goes through your windpipe, your trachea, goes down, and it branches off into many smaller tubes like a tree would branch out. From the trunk, it goes into many smaller pieces. Okay. It gets to these air sacs, and the blood cells go by in a blood vessel real close to where that air sac is, and they pick up the oxygen, and they dump off, if you will, the carbon dioxide. Now the bad air, the carbon dioxide that you made by using up energy, you have to breathe out. You don't use it anymore. The oxygen obviously you have to pick up and bring to your muscles, your bones, your digestive system, everything you need to do to make yourself healthy.
Okay, so let's recap that just for a second. So we have air that we actually breathe into our lungs. It comes through the tubes into the tissues. So I'm thinking of lungs looking like a balloon. So we breathe it in and go, and it blows up in it, and that air, actually the oxygen in that air somehow gets into the bloodstream. So what does it do? Are there little channels that it jumps over, or is it like a high jump, it has to jump over something, or is it squeezed through the cells, or where are we here with this oxygen?
Thankfully, it's nothing like the high jump. I did a little of that in high school. No, this is more like light would be passing through a window.
Oh.
So you see something's there, but there's really nothing that stops it from going across. Just like sunlight would go through a window, that oxygen passes through that little membrane or that space, that very thin tissue, if you will, between the air sac and the blood vessel, quite naturally, because there's going to be more of it in the lungs when you breathe in than there is in the blood. So it moves across to where it's needed, and similarly with the bad air, it moves back out into the lungs, and then as you exhale or breathe out, that balloon deflates in your example, you get rid of the carbon dioxide.
Excellent, excellent. Now let's just break down this fancy word. I love medical terms, chronic obstructive pulmonary disease. Who thinks of this stuff? This is so great, so great.
The main reason you had to go to medical school is so we can speak in these terms that people don't understand.
They don't know exactly what we're talking about. Yeah. There you go. Let's break it down. Now, I know that part of it can be bronchitis, part of it can be that infamous word, emphysema, but does asthma play a part of this as well into the COPD, category? Tell me exactly how it works as far as these diseases.
Sure. So it can be a little hard to completely separate asthma from COPD in some cases. Okay. So asthma, for most people's definition, not just people who aren't in medicine, but for doctors, is a condition where those air tubes close, often because you got an infection or you smelled some perfume or pollen if you're allergic in the seasonal times when there's lots of high pollen. Okay. Those air tubes close down, you have a great difficulty breathing, but when you take medication, the tubes open up almost to normal. Oh. So it is an airways attack, if you will. The air tubes narrow down, you can't move the air. But for most people, asthma is something that can get almost to normal. COPD, as we said in the beginning, really isn't like that. It's a condition that at its best is better than the bad days, but isn't quite normal. Okay. So there can be, some people say I have asthmatic bronchitis. What do they mean by that? They mean that certain things they may experience make their breathing a bit worse, but they have sort of a cough or a bronchitis on top of it. So the way I think of it is bronchitis is sort of at the center of the thing. Bronchitis is the biggest problem. It's 75-80% of most people's problem. What do I mean by that? They have cough, they have mucus, and they have difficulty breathing because the air tubes are narrow and they're clogged up. A lot of people with COPD are constantly coughing up this phlegm that they have a hard time clearing out normally. Okay. Now the emphysema part is what's described more what we would look at on an x-ray or a CAT scan or some sort of picture of the lungs we take medically, where there's areas of the lung that just aren't normal anymore. It's almost like some of them are dissolved away. Oh, okay. They're just, the air sacs aren't there and as plentiful as they were before, so you don't have as much lung. In your balloon example, if you had a whole bunch of balloons, you take some away, the emphysema part of some of those are missing.
Oh, all right then, okay. So when we're talking about, let's go back, we'll talk about emphysema first. I know that there are certain things that they say causes emphysema. And I know when patients come into my office, the first thing they say is, if I say that they may have a lung problem, they say, I don't have emphysema. What would make a patient think they have it, or what would cause emphysema in a particular patient?
So the biggest risk factor far and away for emphysema is smoking.
Oh, okay.
Probably 8 out of 10 patients, or 4 to 5 patients, have a significant smoking history. Now that doesn't mean that a small proportion of patients can get it without smoking. So if they were someone who worked in doing certain type of factory work, or they're exposed to fumes, or perhaps they were in mining at some point, there were a lot of coal dust or sand blasting, things like this, those can also contribute to emphysema. But probably the biggest thing that's the risk factor is, did I inhale things that could have damaged my lungs over time, smoking being the biggest one. Okay. So I'm sure you, like everyone else, is always advising everyone it's a tough thing to stop, but far and away, quitting smoking is the best thing you do to prevent emphysema, and if you have it, to keep it from getting worse. Okay. On top of that, the symptoms that make us worry, or people should be concerned about, is especially if you have a cough that doesn't go away. So one of the ways to look at chronic bronchitis, or bronchitis that's long-term, is if it's present more than 3 months out of every year. Someone who's coughing, and it's not a cold. Any of us get a little virus, we clear it out. If you can't, you may have chronic bronchitis. And if someone says, I have a smoker's cough, what they mean by that in medical terms is I may have the start of COPD. They don't think of it that way, but that's what we worry about.
Now, what I would like to ask is, as far as time, and I know smoking is a very important reason that people get emphysema, how long do you have to smoke to get emphysema? Now, you know, my patients come in and they say, well, I've only been smoking for like 10 years. What's the problem? Why should I have a problem? I know a guy that smoked 90 years and he's breathing fine. You know, why am I having the shortness of breath? So is there a time, or is it, what makes one person 90 years and another person 10 years or 5 years or 1 year and having a problem with smoking?
Yeah, that's an absolutely great question, and patients ask me that all the time as well. I think the true answer is we're not exactly certain why some people get away with it, if you will. I had a neighbor growing up that was just that. He said, I smoked unfiltered cigarettes my whole life. I've never had a cough. I've never had a breathing problem. Everything's good. And other people, my father, for example, smoked far less and had pretty significant COPD. So we know part of it is how much you smoke in a day. So smoking for years isn't just the only thing that's important. Someone who has 1 or 2 cigarettes a day doesn't have the total exposure or the smoke in their lungs as someone who smokes 2 packs a day. So that's part of it. If you smoke 2 packs for 10 years, that could be very similar to someone who smoked a half a pack for quite a bit longer. The other thing is there's a certain sensitivity to it that we don't understand. So we know there are certain genetic or things you can inherit that make you more likely to get emphysema. There's something called alpha-1 antitrypsin deficiency, which if you have it, you're more likely to get emphysema at a younger age and with far less smoking than someone who doesn't have that. But there's other things that make people sensitive that we don't understand or know about. And so, you know, people often say to me, well, I've only smoked 10 years, I'm probably not in too much trouble. And I say, well, I wouldn't get too comfortable. If you can quit smoking now, you're clearly doing yourself a favor and you need to stop.
I hear you. I hear you. Let's talk about bronchitis, because that's a big one as far as I'm concerned, because everybody's coughing and everybody's got a little it's just a little bronchitis and it'll go away. But sometimes it doesn't. Sometimes that cough just lingers. Tell me a little bit about bronchitis, because I know it's different from the emphysema aspect.
It is. And so bronchitis, if you break that one down, because that's again another medical term there, right? Even though we all use it. The bronchi are these air tubes we talked about. It's what gets the air all the way to the air sacs. And the itis part is that it gets inflamed, it gets irritated. So if someone who's been previously healthy, never had a lung problem, gets a virus, and they say, I got viral bronchitis, you could imagine those air tubes are excited, they're inflamed, and any little thing causes you to start coughing, and sometimes with a cold we can get a pretty bad coughing fit. But we all expect that to get better, maybe in 5 days, 7 days, or the worst case is a few weeks later after a bad bout, we're all over it. When someone smokes and has chronic bronchitis, that continued smoking is every day irritating the tubes like the virus would, and it doesn't go away. And that's why someone that gets up and has the morning cough or the smoker's cough, it could be a sign that that damage isn't going to be reversible after a while. And why they should really look at smoking as something that there's no amount of smoking you can do that's healthy or that's okay. A small amount is better than a large amount, but you can never stop smoking sort of too soon. Never anyone said to you, right, oh, I quit too early, should have smoked longer. It doesn't happen.
It doesn't happen. You're right. Now let's just think about it this way. The cells in the airway. Alrighty, and you said that the smoke, and I'm sure there are other things that can cause damage to the cells as well, like as you said, where you work and inhaling toxins or something like that, or cleaning solutions that you're inhaling and you get too much of it. What actually happens to the cells? Do they kind of balloon up, or do they break apart, or do they you know? What happens that makes them inflamed? And I know all the mucus and stuff. Why do I get all this mucus and coughing and no matter what I do, it's like just ugh. That's how I feel. Ugh. You know what I mean?
Yeah.
I mean, why does it happen? What's happening to those that at the cell level once I irritate it, I should say, that it really just doesn't go away like it should?
Well, the way I explain it to patients often when they ask that is, think about what your air tubes in your lungs are supposed to do besides the good things we talked about, get the oxygen in, because your lungs are trying to do that all through smoking. One of the things they're trying to do is get rid of the things that you inhale that shouldn't be in there. You know, you walk through a cloud of dust, it sticks to the airways, to the mucus, and then you should be able to cough and get it out. If you're eating, something goes down the wrong pipe, as we say, you cough and you get it out. So that sensitivity that's there increases in smoking because it's sort of like the body doesn't realize that the smoke's going to keep coming and coming. So each day, the nerves get a little more sensitive, and they get to the point that little things can really make you cough. So there's changes in the nerves. Since the mucus is supposed to trap the things you breathe in and help you get rid of them, in most smokers, the amount of mucus cells increases. So that means you produce more mucus. The factory for the mucus goes up. So you actually make more mucus than non-smokers do. And then another thing is that the cells that normally just line things form the walls. They'll be like if you cut yourself or got a scrape and everything gets all red, that's your body's immune system moving white blood cells in to try to fight it, if you will. I think it's something they can capture and win a little battle with, but the smoke's there every day.
Right.
So you get a bit of those cells, and that's what we mean when we say the inflammation. If you could look in there like you looked at a scraped piece of your skin, you'd see that it was red and irritated, but nobody touched it. It's that the smoke got in there, and the smoke itself sort of caused that problem.
Okay, so we're talking about smoke, we're talking about chemicals, we're talking about anything that can irritate your lungs.
Sure, I'll say smoke because smoking's so common, but absolutely,
Right.
It can happen from things other than smoke.
Okay, another thing. I read somewhere that your stomach acid sometimes can regurgitate, and we all eat a little bit too much or a little hot peppers or something, and it gets a little, and just a little bit of that can get into the back of the throat or down the airways and irritate, or like postnasal drip with your sinuses. A lot of people have seasonal allergies. How does that play as far as irritating the airways and causing bronchitis?
Yeah, so when we run down the most common causes of cough, COPD or smoking could be one of them, but someone says, I never smoked in my life. I work in a relatively clean office. Why is it that I always have this cough? I have essentially a bronchitis that doesn't go away, and those are two of the biggest things. So stomach acid obviously is what we need to break down our food. It's important, it's necessary, but just droplets of that coming up and getting in the very sensitive lining of the lungs cause a lot of the changes that could look like, if you just looked at it, with a microscope or got in there and looked at it, could look like what the smoking damage does. It's a pretty severe irritation. Okay. And so people that have acid reflux that every day, not just with some peppers or a meal like you said, but every day get that reflux or the acid coming up, can get a condition of long-term or everyday cough. That's essentially a chronic bronchitis. Postnasal drip, very similar. If you have, say, allergies, your nose is always inflamed in the spring, and that causes the mucus to drip down, some of that's going to hit your vocal cords, sort of the doorway, if you will, to your lungs, and some of that's going to drip down and irritate the lungs. If you can fix those problems, like stopping the smoking, that chronic bronchitis should get better.
Get better over time.
Yeah.
Now, is there usually an infection associated with it? I mean, from the way I look at it or think about it, I think about it this way. If there's mucus down there and bacteria loves mucus,
absolutely,
then there must be some bacteria. So how do we handle that? How do we get that part of it under control? What do we do about, because we're one big, as we call, petri dish. A petri dish is a little dish that you spread the bacteria and let it grow, and that's what we are. That's what our bodies are. So is that a component of it as well?
It is a component. So anyone with a lung illness, and COPD is a classic example, it's one we talk about all the time, they're much higher risk of getting any infection. So before we even talk about bacteria, we got to tell people this time of year, they have to get their flu shot. If you have COPD, you're a smoker, one of the best things you can do to prevent a serious pneumonia, right. You and I might not get as sick from flu as someone who has COPD, right. They get the flu shot. Right. Many of them should talk to their physician or provider getting a pneumonia shot or a pneumonia vaccination. Then there's the bacterial piece. All of us, as you said, get us some bacteria in, we got to clear it out, or we start to grow it. COPD patients are at much higher risk of getting a bacterial bronchitis. And it's one of the reasons why if you go to your doctor, you go to your provider and you say, the cough has increased, the phlegm's a little more gunky, junky, it doesn't look as good, the chance of you getting an antibiotic is going to be pretty close to 100%. If you get admitted to the hospital, it's a standard of what we do. We give anti-inflammatory medication, inhalers to help you breathe better, and we're going to give something to treat that bacterial infection because likely it's there. And that's another way when you say, well, what's asthma like compared to this? Someone who has pure asthma, their risk of an infection that needs an antibiotic is actually quite a bit lower. But COPD being there all the time, the bacterial infection risk or bacterial bronchitis is much higher.
Oh, interesting. Now, in your office, I'm sure you see patients like this all the time. What's the typical patient or how do they present when they come to your office and trying to figure all of this out? I mean, do they kind of know what they have, or they're really in kind of la-la land trying to say, doc, just help? How do they present usually?
A lot of the people aren't real clear about what's going on. They'll come in saying, I'm trying to understand what's happening. I work in a job where I'm moving things around, and I'll tell you, I noticed last year I did pretty well through the winter. This year I'm coughing a whole lot more, but I'm told I don't need any antibiotics, and I'm just always a bit more winded. And yeah, I smoked, but I cut back a little bit, and I smoked for years, so I don't see why suddenly that's catching up with me now. And we talk about the whole thing, and we start going into some of the testing we do, and we say, The smoking's not a good idea. I've said it a few times already, but we got to stop that. But let's dig a little deeper and find out what's really going on. So a lot of them don't know when they come that they have COPD.
I hear you. What about age? Does age play a difference? Is it more common in young or more common as you get older? What about age? Does it play a factor in these diseases?
So it's almost always more common as people get older. You almost never see someone in their 20s, say, with COPD. There have been cases, I can't say it doesn't happen, and no one should ever get totally comfortable saying I'm 27, it can't possibly be. But it's far more common as someone smokes longer or has that exposure at their job to something that could cause it, that they get it more frequently. Most of the patients you described, the first patient would come to me and say, what is this? They're in their 50s often, maybe in their 60s, sometimes in their late 40s, but they tend to be a bit older than, say, the school age or young adult population where they're first seeing this.
Okay. And what about gender? Is it more common in females or more common in males? That type of thing as well.
That's a great question. Well, it has for many years been far more common in males than it's been in females. And largely that's because if you looked at who smoked, a lot more men smoked than women. But what's unfortunately happening is a lot more young women have been smoking, and there's been this whole thing about, smoking's for everybody, and there's been a lot of advertisements sort of showing women with their Virginia Slims, say, and they're looking kind of cool. And so when you look at something like that, you've come a long way, baby. There's more women that got exposed and unfortunately now have COPD. So I don't worry about it any less when a woman comes to my office with those symptoms than I do in a man saying, well, you're much less likely. I'm looking at both of them and being concerned that that's a problem.
All righty. Very, very good. And as far as race is concerned, I know these are classic questions, but do race play a part? I mean, are African Americans more likely to have it than whites or Asians, or how do you look at that?
Compared to a lot of illnesses where we can really say this is much more common, say in an African American population, much more common in a Caucasian population, COPD is somewhat equal in terms of the way it does its damage. When I'm in a group of patients, I'm not looking at, say, a support group where people are asking questions about these, maybe in a patient outreach session, and saying, well, you don't have to worry about it because you're Asian. Everyone who smokes or could have that type of exposure could end up developing this illness.
Okay, all right. Now, we know how it presents. We know some of the symptoms that may arise, that would bring them to your office. But once you diagnose, I'll put it this way: how do you diagnose it? Let's not bypass that. How would you diagnose it? What do you do?
You can get most of the way there just by talking to the patients and doing an examination of it. It's like a lot of things in medicine, the testing's helpful, but someone who tells you I've been smoking for years, or I've been working in this factory and it's constant cement dust, or I've been working at a job site in construction, and I have this cough that doesn't go away, and I'm getting more short of breath with this, already, we're running this list in our head as doctors, and we're saying COPD is right up near the top of that. You do some additional things after that. A chest x-ray is very, very common, and it's recommended. Make sure it's not something else. People with COPD are unfortunately at higher risk of getting cancer. So at the very beginning, you're looking at that and saying, okay, does it look like COPD, and do I see anything else there that I have to worry about? We commonly also do a breathing test, pulmonary function tests, or patients often say PFTs. And it's an interesting thing. They put a little hose in their mouth, and we run it through a series of lung exercises, if you will. If you were applying to get into the military and they say, well, how many push-ups can you do? This is like the lung push-ups in my mind.
Okay.
Deep breaths in, all the way breathing out, and we measure that against people who are their height and their age. And if they can't move the air, especially early on, and there's that obstruction, the O part of COPD, we've got most of the picture to put together and tell them that's what's going on.
Interesting. Now, I know that we're summing up here. As far as medications are concerned, I know there are a lot of medications out there, but I know there's some mainstay medications and things like what I know, bronchodilators and medications like that. Just not specific medications, but what are some of the medications that we have that we can use to help these people?
Sure. Well, we have what we think are sort of the two categories, if you will. We have the short term, are the ones that relieve symptoms right up front, and that would be one of the inhalers that even asthma patients tend to carry around. It's a little canister type thing. You see people on the street, on the bus, all over the place, putting it in their mouth, taking a couple puffs, and they get to move on. That helps open up the airways, helps them breathe better, and is a good thing, but it doesn't make the illness better. For many people who have chronic cough, we got to give them something anti-inflammatory, different type of inhaler they use for that.
Gotcha.
So most of it's inhaled medicine because it goes into the lung.
Oh, all righty. Well, I know that we could talk more and more about this topic. It's such an interesting topic. I truly appreciate you coming on and just covering COPD for us, because it's, as you can see, it's one of my favorite topics because it involves the lung.
Thank you.
But we're going to have to get you back, cover some other interesting entities as far as pulmonary medicine is concerned. Thank you very much, Dr. Studer, for coming on.
Thanks for having me. It was my pleasure.
All righty. Well, I think it's that time now. I think it's time that we need to, just put it this way, let's talk. Let's talk about a few things. I'd like to talk about medications just for a minute and how you take your medications and why you take your medicine. There are certain things we need to know about. There are people out there that, you may have never taken medications before, and all of a sudden the doctor will prescribe something to you. And there are certain things that you should really realize. Number one, when the pharmacist gives you the medication, always ask the pharmacist, is there a specific way I should take it? Should I take it with food? Should I take it without food? Or can I take it with other medications at the same time? Or should I stagger them? These are some of the things that we need to know. We need to know actually also whether I should take it 2 times a day or 3 times a day, or should I take it every other day? And how do I remember to take my medications? That's good too. Should I take it in the morning with my breakfast, or at the evening with my dinner, or after I brush my teeth? And these are some of the things that are so important as far as medications are concerned, because you can have side effects. If you don't take the medications appropriately, they may not work for you appropriately. They may make your stomach upset. You may get a little dizzy because the combination of medications that you're putting together are, just don't go with each other. So these are some of the things that I just want you to think about as far as medications are concerned. In closing, remember, sharing and caring, www.medmoments.com. I'm so happy to receive all the emails that I receive, and it allows me to continue to bring topics to the show that are pertinent. Never institute any change in your medical care until you consult your doctor. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.